All right, welcome everyone. We have 100 people on here, which is great. And people at this moment are putting where around the state they're coming from. We have really good representation from around the state. And I think you're all going to learn a lot. So today's panel is on preparing for mental health crises. I'm Dina Schwartz. I'm the director of New York State Guardianship Initiatives at Project Guardianship. And we are very thrilled to present this panel to you. Just briefly about our organization, Project Guardianship was founded in 2005. We were a program of the Vera Institute of Justice, and there was a gap where a population of largely low-income aging adults and people living with disabilities and mental illness who lacked family and other supports were left unprotected and without assistance. And so Project Guardianship serves as a guardian regardless of a client's ability to pay. And with the ability to provide services for complex cases. We also do research, provide education like this, and advocate for better policies and practices. So this webinar has come from conversations with attendees after our Good Guardianship and Autonomy Preservation Coalition had its kickoff event in the fall. There was a lot of interest in getting tips and learning more about working with people living with mental illness. And then Dr. Ghamar was at that event, and she and I had been talking, and she came up with this great idea for a simple tool. And this kind of unfolded from there. So you all had some great questions. Thanks for those who submitted in advance, but we should definitely have time for others to ask questions today. I will mention that Dr. Ghamar will be referencing a tool that she created. You all should have gotten it in an email. If you happen to register in the past, maybe 10, 15 minutes, it might mean you didn't receive the tool, but I'll make sure that everyone who attended gets it after. And if you didn't get it, feel free to reach out to me after. So I am, right before I let the panelists introduce themselves, I'm going to launch a quick poll just to get an idea of who is in this room with us. It should be launching now. I'll give you about 30 seconds. You can click whichever one you most closely identify with. All right, we have almost full participation. I'm seeing that we have a lot of legal services, people from government agencies, judges and court staff, a bunch of guardians, but really, really all over community-based organizations, healthcare services, mental health services. The results should be shared with you right now so you can see. Great. We have a great mix here. So I'm going to stop sharing those results now, and I'm going to turn it over to Katie, Dr. Goettsche, to introduce herself. Go ahead.
Hi, everyone. My name is Katherine Goettsche. I'm a geriatric psychiatrist. I'm an assistant professor of psychiatry at Weill Cornell Medicine, and I also work with New York City Elder Abuse Center. I see patients at the New York Presbyterian Westchester Behavioral Health Center. I mostly see older adults in an outpatient mental health clinic. And I sit on a multidisciplinary team in the Bronx where we work with, it's a collaborative effort to reduce risk in cases of suspected elder abuse. And that's where I had the pleasure of working with Dina in the past. Previously, I've worked on an inpatient unit and in a collaborative care setting. And I'm happy to be here today to speak on this important topic.
Thank you. And now I'm going to turn it over to Dr. Ghamar, who will introduce herself and then launch right into her presentation.
Hi, everyone. I'm Dr. Jaclyn Ghamar. I'm a licensed psychologist in private practice in New York City. I'm licensed in Connecticut also, as well as a telehealth provider in Florida. So in my practice, I provide psychiatric case management, coaching, and therapy for individuals with mental illness. So I help young adults take steps to integrate their mental illness into their lives without making it their sole identity. The work is very goal-driven and action-oriented. And I also provide coaching for parents with children who have severe mental illness. I work with them to better understand the nature of the child's mental illness. I work to improve communication, create better boundaries, adhere to limit setting, manage crises, and just sort of be consistent in their efforts all around. And in all of the work, we try to avoid crises. Sorry, Manhattan. We try to avoid crises, but when they do occur, it's sort of important to have a plan of action in place. So as you registered for this webinar, you should have received this mental health crisis planning form. Before I describe the plan and the form itself, I think it's important to define what a mental health crisis actually is. So a mental health crisis is a situation in which a person's behavior puts them at risk for hurting themselves or others, or when they're not able to resolve the situation at hand with the skills and resources available. So a mental health crisis plan is a plan of action that's made before a crisis occurs. And this is really the important thing, the preventative measure. So an individual and their support system know what to do when an emergency actually happens. And what I like about this form is that it's a combination of mental health plan and portable treatment records. So it can be used in emergency situations, but when you see a new provider or you're seeing an old provider and want to give a little more background information, you can just share this document that you've completed with them so that they know all of the variables at play here. Again, the way to manage a crisis is to be prepared for it. So the plan itself is for really anyone. So somebody with mental illness, somebody who has a loved one with mental illness, somebody who works with or supports somebody with mental illness. The plan can be completed by the person with mental illness. It can be completed by those working with the person with mental illness. It can be completed by the individual's loved ones or providers based on their experiences with them, or really based on a record review. It can be completed collaboratively with a provider or family member, or it can be completed alone. So why is it helpful to have this kind of plan in place? I think we have all seen that in emergency situations, regardless if it's a mental health crisis or some type of other emergency, our ability to think rationally is kind of depleted. We kind of go in autopilot, and sometimes we don't make the healthiest decisions because we're not really able to think so clearly. When it's a dangerous situation or a situation where danger could be happening soon, our fear might get in the way. And given the mental health concern of some of our clients or loved ones, the idea of having to call 911 means that there's some repercussions, right? They're going to be mad at you after, regardless if it was the right thing to do or not. And some people don't really want to or are able to tolerate that. So the other piece is that, in my experience, the people that I've worked with, the family members, their frustration tolerance for safety concerns and danger is much higher than it actually should be. You know, they've been in and out of the roller coaster of crisis mode for years. So they may not be perceiving a crisis when a crisis is actually happening. So when you have an emergency action plan in place, you and your support system, you know what to do, you know who to contact, and you know what type of help to give when the time comes. So I want to make sure that everyone is sort of looking at the plan itself right now. Dina, is that possible? Thank you, Assistant Dina. Okay, so let's check out. So this is, I filled out a sample plan for Jane Doe, and she filled it out with her case manager, Sarah Smith. So the first page is sort of basic demographics, helpful to have some background information here, just your name, date of birth, address, some medical information, diagnoses, I really like the inclusion of the communication barriers because not everyone can communicate the same way. I think it's important to include people that are hard of hearing or may communicate differently than we are expected to, or that is typical. And if we scroll down a little bit, we have some basic medical information with diagnoses. We have meds, surgeries, allergies, primary care doctor, pharmacy name, the whole shebang. Page 2 is some more psychiatric focused background information. I think when psychiatric emergencies occur, we want to know a little bit about the person's history. Maybe we don't need everything from like 10, 20 years ago, but their more recent history to know what is sort of their baseline and what has been actually happening. History of hospitalization, suicide attempts, substance history, self-harm history, violence history. This is all really important for the people that might be intervening in these situations. And, should this turn into a hospitalization, it's really important that the hospital has more information about what is actually happening. So if we can go down a little bit. Self-harm, psychosis, these are kind of big questions that will be asked if somebody else has to intervene. So if we kind of check out page 3, I would say most of the information in this form is pretty straightforward, but I think for our purposes here, page 3 is probably the most important. So as we're thinking about this plan, it's important to note that no two plans should look the same. What works for you is not going to work for me. What triggers Jane Doe's psychosis may not trigger Michael Doe's psychosis. So this is not something that we kind of want to just bulk duplicate for all of our clients or the people that we work with. That's not how this works. So two people really should not have the same plans. They really should be unique to the individual and what's happening in their lives. So the first section we have is early warning signs of a potential crisis. So these are observational signs that a crisis might be impending. So we have sleep changes, hygiene changes, isolation, missed appointments. In the case of Jane Doe, her early warning signs are an increase in paranoia, specifically related to technology, hearing voices, a decrease in showering, hygiene issues, sleeping too much or not at all, agitation and missing appointments. So in some cases, the individual with mental illness will be able to connect these behaviors and sort of internalize, okay, I'm having some early warning signs here. But in a lot of cases, they're not going to have the insight enough to know this. And this is where it really is helpful for somebody else to have some of this information so that we kind of are able to pinpoint those red flags. Okay, next we have the triggers to a crisis. These are known actions, events, behaviors that might bring about a crisis. So examples include missing medication, conflict with family members, substance use, a loss, a move. Jane's examples of triggers for her crisis are fighting with her boyfriend, running out of money, which is something, unfortunately, that a lot of people have to deal with, and taking her medication inconsistently. We know that slipping from that can really decompensate somebody. So knowing somebody's triggers can help better prepare for or take steps to avoid a potential decompensation. So the holiday time is a real big trigger for a lot of people, a really great time for a lot of people, but a lot of people really get distressed by it. So we want our clients to know that they have some tools in their pocket to manage this distress so it doesn't turn into a major crisis. So now we have coping strategies you can use. So these are things to manage distress. And ultimately, the hope here is that the individual will utilize their coping strategies to decrease their level of distress so that we don't have to take more serious measures, but this isn't always possible. So examples of coping strategies are calling a friend, listening to music, meditating, drawing, knitting, yelling into a pillow. My favorite, for those who know me, is getting an ice cube and letting the ice cube melt in your hand. That really seems to quiet a lot of distress. In the case of Jane Doe, her coping strategies are to take her medication, watch her favorite YouTube video, call her sister, journal, play solitaire, or use some other type of grounding strategies. Again, we want to encourage them to use these strategies if we can, but there is no guarantee that the strategy is going to help quiet their level of distress to avoid hospitalization or other more severe measures. And so after this, we have support system. It's family, friends, peers we can reach out to during a crisis. Jane wants to call her sister and her case manager. Most of us have someone we can call to talk us off the ledge, and this is who we want to encourage the person to call. In the case that you don't have somebody like that, 988, give them a call. Maybe they can talk you off the ledge. Okay. And finally, we have safe space. And I think that this is a really important one. How do we make the space that they're in feel safer for them? So examples include removing knives. Hopefully they don't have really sharp knives, giving a family member or friend medication or drugs. In the case of Jane, she's making her safe spacer by throwing out her marijuana. And if you looked at this example before, we noted that when she stops taking her meds, she starts using marijuana quite regularly. And so if she's not able to throw out her marijuana, she's going to ask her boyfriend or her case manager to do so. And then again, the safety concern here is that if you are in this room with the individual and you are concerned about your safety, you need to leave the space and call 911. Okay. So we have sort of this very brief overview of what this tool is, and I think we kind of need to figure out how to introduce it to people. So I really like the idea of framing this plan as an empowerment tool to ensure that the individual's preferences are heard. And I think it's always important as clinicians and people that work with people with mental illness to help them engage in activities that allow them to identify their preferences and share their preferences. And I also think it's incredibly helpful for them to take an active role in their treatment planning process. We don't want to, if we can avoid it, we don't want to fill this out by ourselves. We want them to feel part of the process and take ownership of their mental health and be, an advocate for themselves. The pace of the completion of the form is really dependent on the person. Some people are going to want to fill it out all at once, get it over with. Some people are going to want to fill it out in multiple meetings. Some people are only going to want to fill out a section. That's okay. And some people are not going to want to fill it out or are not going to be able to fill it out. And that's okay too. In this work, we never want to force anyone to do something that they don't want to do. That's not going to be helpful for the individual with mental illness, and it's not going to be helpful for your relationship with them. So we don't force. And once the plan is completed, it's sort of helpful for it to be kept in a safe but accessible place. So if the individual with mental illness is comfortable, they should share the plan with their roommates or loved ones. And maybe if they're not comfortable sharing the specifics of the plan, they can share the location of the plan with their roommates or loved ones so that they can be prompted to use the plan when they're in distress. If they are allowing other people to see the plan, the loved ones or supports can focus on some of these observational things that we've identified and see what action needs to take place. And if the individual isn't really comfortable sharing the plan, I think it's still a really good exercise to have them to start thinking about their mental health, their preferences, and again, to take an active role in their treatment planning. I would recommend practicing using this plan. So reviewing it regularly and helping the individual implement some of the strategies during times of distress. So you can prompt a person to use a previously identified coping strategy outside of a crisis. So let's say Jane has a fight with her boyfriend. You can prompt her to call her sister because that's something that she has identified as something that can help her distress, or you can recommend that she watches that YouTube video that she loves to quiet her agitation. And I think it's also really helpful to periodically update the plan because people's preferences might change. And so the last piece here is, I think it's really important to remember that this is not a legal document. There's nothing about this that's legal. This is a tool that can help us in these situations. But just because somebody's writing their preferences down doesn't mean that anyone has to follow it. So if Jane Doe really prefers to go to Bellevue, but EMS takes her to Beth Israel, that's out of our control. And that's something that we have to deal with. And again, a final reminder, if you are feeling like the individual is in danger to themselves or somebody else, call 911. And if you don't feel safe, you need to leave the room. Okay.
Great.
That's me.
Thank you. So I know that in the event description, we mentioned that we would have about half of the time for Q&A, and we do. Part of that is going to be embedded right now into some questions we got specifically about the tool. And then we will go on to Dr. Goettche's presentation and then have time for questions for both after. So, I mean, you sort of answered this question a bit, but how do you start this type of conversation when it feels uncomfortable? And not just that it seems like the person doesn't want to answer, but you as the person feels uncomfortable asking these questions.
Well, I think these are uncomfortable questions to ask. And I think that you have to check in with yourself to find out why you're feeling so uncomfortable about this. You know, I think that in much of our work is to help empower and advocate for these individuals. And we can't really do that if we're afraid to ask those really hard questions, right? Like, we're framing this as an empowerment tool, but if we're not confident in ourselves to ask those questions, it's not going to come out that way. And who's going to want to fill it out?
Yeah, that's a good answer. You, as part of the form, suggest asking about people's support systems. If you're sort of working through these questions with someone, is there a time when you should start, as a provider or family member or whoever, start engaging others in the support system in working through these questions as well? Or should you?
So I think all of this is really up to the individual with mental illness. It's, we again want to empower them. We don't want to go behind their backs and be like, okay, I'm the provider, I'm going to call your sister and tell her that we worked on this. That's a HIPAA violation often, right? Like, we want the loved one, as much as they can, to tell us how they want us to handle this form. If their sister, if Jane is okay including her sister in some conversation about it, and if she is, great, and if she's not, okay.
Right. So speaking of HIPAA, a question that was asked while you were giving your presentation is this plan something that you would share with the police department or other officials? Would that be a breach of medical information?
So I think that's a tricky question. If it's a serious situation where you're calling 911, I think you likely can, right? Or you can summarize some of this information over the phone with them. When the person is in a dangerous situation, HIPAA goes out the window. If the person is having like a mini crisis and the police come, I don't know that you want to offer this information because it doesn't seem like it's a dangerous enough where you can break HIPAA violation.
All right. So I think the other questions, we had some people raise their hands. So give me a second. To find you. Olga, I'm going to
Hi, Olga.
unmute you. Or I'll make it so that you can unmute if you wanted to ask your question that way.
I don't know if there's another Olga. I didn't have a question.
Oh, sorry. I saw your hand was raised.
Nice
it
to see you,
was?
Olga.
Oh, that was nice to see you. Nice to see you all. Thank you. Thank you, Dina.
Sure, no problem. I'll unmute you.
No.
All right. So if we don't have any more specific questions, we have much more questions, but for later, but specifically for this tool right now. Oh, I see Terry. Terry, I'm gonna unmute you.
Hi, I'm a social worker and a lawyer in Nassau County. I've been an active in guardianship practice as an attorney for 25 years. And maybe I'm missing something, but I'm looking at the form and I don't see any place where the person's psychiatrist is listed. I mean, I would think more than the primary care physician, you need a line for the psychiatrist.
You're totally right. There is a line if you go to the end of the form on the final page that talks about
Oh,
yes, on the top of the
Oh,
final
okay.
page it
I'm
says
sorry.
providers there. Yeah.
I thought it would be with the other provider.
I did it that way specifically to differentiate between the medical and the psych.
Okay, I'm sorry.
No problem.
Thanks for
Maybe
the
I should
question
learn
though.
how to read to the end of forms.
It was a good question. You're right. It should be on there and it is on there. All right. So I am now going to move it on over to Katie, to Dr. Goettsche. Sorry, we know each other for many years. But we will have time for more people to raise their hands if you want to ask questions after. And we'll get to other questions that you submitted in advance. So I'm gonna turn my video off and turn it over to Dr. Goettsche.
Okay, I am going to share my screen and show some slides I prepared. So bear with me. Okay. Can everyone see?
Yes.
Yes, okay, thank you. All right, so I'm going to speak on special considerations in treating older adults with mental illness. So by mental illness, that includes diagnoses such as depression, anxiety, psychosis, substance use, neurocognitive disorders, which is the updated diagnosis for dementia. And this is not comprehensive. We see bipolar disorder, we see personality disorders that exist in old age. And these diagnoses frequently co-occur. They frequently have overlapping symptoms, and they're a major source of suffering, morbidity, and disability for our older adults. It's prevalent. To give a picture of prevalence rates, we see depression depending on the population at rates from 2 to over 30%. And prevalence rates are higher in the hospital in cases where home care is required and in those with medical comorbidities. We know that depression is in general under-recognized and under-treated. And so these numbers are estimates, and they're probably higher in the population than what gets captured in these screens. Neurocognitive disorders or dementia exist at rates of about 5 to 7% at age 65, and this number increases steeply with age. These rates can double with age. So in mid-70s, rates are close to 15%. And then insomnia, prevalence around 10 to 15% in older adults, and probably higher than that. But again, this is what gets captured on the screens. Okay, I want to pause before we zoom in on this slide. This slide is meant to represent the complexity of mental health in older adults. And I'm sharing this as a snapshot into how I think about mental illness in older adults from the perspective of a psychiatrist. So I'm going to draw your attention to a few things on this slide. One, I want you to sort of look at this with your eyes half closed, pretend it's like one of those magic eye books where you just sort of squint and try and get a general picture. And the sense you'll get then is that there's lots of factors here at play that influence mental health in older adults. And these factors interact with each other. So you see arrows that point both ways. So for example, depression and pain talk to each other. The experience of pain can be exacerbated by depression. Pain can induce symptoms of depression. And so this is not one size fits all. We can imagine if we were to map in additional factors like arthritis, anxiety, delirium, substance use, that this can expand and get more complicated. So that's number one, is that it's complicated and multidirectional. I want to draw your attention to this triad here between depression, neurocognitive disorders, aka dementia, and certain medical factors, especially cardiovascular disease. That includes diagnoses like high blood pressure, high cholesterol, and stroke. We know that in individuals who have had a stroke, there is increased vulnerability to depression. In fact, there's a diagnosis called vascular depression. There's a syndrome that's characterized by apathy, withdrawal, executive dysfunction that we know and understand to be the result of stroke. We can also see this in the context of chronic ischemia and inflammation in the brain. Neurocognitive disorders can also develop as a consequence of stroke. There's a diagnosis of vascular dementia. Depression and dementia diagnostically can look very similarly. They can coexist. They can mimic each other. They can disguise each other. And so much of my day-to-day clinical work is disentangling these diagnoses and treating depression where it exists. It's a misconception that depression is normal with age. Yes, there are circumstances. Yes, there are transitions in life that can induce depressive type syndromes, but depression remains a clinical entity that is treatable, that is multifactorial. Just a couple other biologic factors to highlight. Family history is an important determinant of depression at all ages. And some of the medications that we use to treat for depression, when given over decades, can exacerbate metabolic conditions that increase risk for some of these vascular risk factors. So that's another consideration with the elderly. So now, going to the next slide, I want you to sort of zoom out the lens. So we just did a deep dive into biologic factors of mental illness in the elderly. We think like Google Earth, we're zooming out now and we're looking with a broader perspective. And we're looking at the biopsychosocial model where the last slide covered these biological factors. Okay, psychological factors related to advancing age include grappling with conflicts of integrity versus despair. As someone reflects on their life, do they feel connected to meaning, purpose? What are areas of regret and pain? Grief comes up with age. Coping styles that are adaptive, that are maladaptive. Where are the sources of resilience? Social factors include traditions, loneliness, financial strain or strength, abuse, trauma, neglect. This is a lens that's useful, I would say, with all ages to conceptualize the factors that influence the expression of depression, that also highlight areas of strength to build on, and is a very useful way to understanding our older adults, especially who, with increasing age, life experiences, there's much to draw upon. Okay, this I think is going to be an area of interest, just practically speaking, clinical factors of late life depression that differentiate depression in older adults from depression in younger adults. So depression could present with apathy, withdrawal, psychomotor slowing, cognitive blunting, reduced appetite. You can picture someone slowing down their speech. They produce less speech. They take more time to respond. They seem confused or more forgetful. They may withdraw from social activities. They may stop going to church. These are all symptoms that individually may be written off as, oh, it's old age, oh, they're tired because they're old. But when we look at the whole constellation, may be consistent with a syndrome of depression that we want to identify so we can treat it. Somatic ruminations, preoccupations, or delusions exist on a spectrum. So if someone's preoccupied with this idea that they're unable to swallow, and I've seen cases where individuals become dehydrated, they lose weight, they have hospitalizations for failure to thrive, they have many studies, tests, imaging to rule out cancer or obstruction or medical illness causing these symptoms that come back negative, and the individual is not reassured. When that individual gets treated for psychotic depression, they get better. So it's tricky in the elderly because these are not uncommon symptoms that an older adult might experience. Constipation, reduced appetite, difficulty swallowing, signals a medical workup. But if it doesn't get better and there's no findings, we want to think about, is this late life depression? Delusions of poverty. One can be convinced that they're going to be evicted, that they're in tremendous debt, that they have no money to live on, that their family is better off without them. And this can lead to thoughts of suicide or profound hopelessness and ongoing distress. And again, this too, we have to take it at face value and take it seriously. And when family members or case managers or other people who know the patient can speak to, this is not the case. You have savings, you're making your rent. There's no eviction proceedings underway. And the individual isn't reassured by that. We think, is this a delusion? Is it a fixed false belief? And that requires treatment for depression. Age-related health conditions affect diagnosis and treatment. So diabetes, hypertension, chronic pain, any number of medical illnesses of old age can present with low energy, fatigue, malaise, weight loss. So we need to pay attention to these conditions and make sure they're being treated, but also consider the possibility that depression is a contributory factor. And then lastly, I wanted to highlight that suicide rates are high among the elderly. And some correlates of suicide risk include hopelessness, guilt, feelings of being a burden, giving things away. If someone stops taking their medications, if they're experiencing acute or chronic stressors that they're struggling to cope with, if they're isolated, withdrawing, if they have access to lethal means, do they have a gun? Do they have opiates? Are they on pain medications? And do they have a personal or family history of suicide or suicide attempts? All of those increase an individual suicide risk. And so we take that seriously. And so to wrap up, I want to convey that late life depression is well characterized, and it's an important area of research. The hospital where I work, we have an Institute of Geriatric Psychiatry. And so there's interest and understanding and knowledge about this as a clinical entity that understands that age-related factors influence how depression presents, and then how it then requires treatment, and how treatment is different for older adults than from younger adults. And yet access to mental health care is so limited, especially to our most vulnerable elders, and these barriers are significant. Yet treatment is in many cases helpful, sometimes curative, and in some cases harm reduction is life-saving. So all of that to say that these efforts are very important and can really make a difference in the safety and well-being of our older adults.
Thank you. All right, so we are going to get into some more questions that you all sent in advance. So before I invite Dr. Ghamar back, Dr. Goettsche, so someone asked a specific question related to sundowning and when a person's capacity waxes and wanes. How do you address issues? And they were specifically asking about non-compliance with medication, but just in general, how do you address issues of self-determination when you see someone's level of capacity waxing and waning throughout the day?
This is a wonderful question. It's a really important question. I smiled when I saw it. It's the heart of what I think about on a day-to-day basis, and I'll try to address it without introducing more questions. So just as a definition, sundowning is a term to describe the restlessness, irritability, confusion, and physical agitation that tends to happen as daylight fades. And we often see this in patients with dementia and or delirium. So in general, how we decide to approach this dilemma between autonomy and self-determinism and the need to take medication to ensure safety, physical safety. And I think that's best addressed by giving a few examples. It depends on the question of safety and environment. And we like to have those two things be congruent. So if we're acutely concerned that when someone's sundowning, they're physically agitated, maybe they're aggressive towards their caregivers, they're aggressive towards themselves, they're at risk of falling out of bed or getting up when they're not supposed to, when they require assistance to get up, and putting themselves at risk of falling and breaking a hip, which can be, sort of a devastating outcome in these cases. We like to have safety and environment be congruent. So in the extremes, in the hospital setting or in a nursing home setting, there's more flexibility to manage these acute symptoms with the resources that these more structured and controlled environments have. So you can proactively manage the sundowning with environmental cueing, bed near the window, prompting, that sort of thing. And hour to hour, their mental status can be addressed and managed acutely with medications through the vein, if required to be, if needed to be given over objection for acute safety concerns. What we're probably more experiencing is in the community. So there's more variability. We look at, what were the individual's wishes? How much freedom can they safely have? And what are the hard stops? What are the boundaries? And this almost always needs to be decided together with family, guardian, with clinical input. So for example, if an individual is refusing their antidepressant and expressing suicidal ideation, if they have a history of suicide attempts, this becomes an acute concern. This is someone who would probably try and get into the hospital setting. If they're refusing blood pressure meds and have a history of stroke and their blood pressure control needs to be tightly managed, maybe they can go a week without taking their meds and that would be okay. Maybe it's not okay. Maybe they need their blood pressure checked twice a day, twice a week. If they're refusing blood pressure checks, maybe they need to come into the office for a checkup. If they're refusing that, maybe they need to go to the ER. So having a plan with a primary care doctor or whoever's prescribing the meds who can help gauge what is the risk of the decisions that the individual is making is going to be necessary. There's many other examples we could think about. Is someone refusing a blood thinner, but they have blood clots, and that's a high lethality condition. Potentially, they may not be able to safely refuse that and require hospitalization. So, but what we're sort of dancing around is that one can have a guardian and lack capacity, or have a healthcare proxy advocating, or have a doctor advocating, and still we can't control things. Do they take the medication or not? So in that case, then we try to control the environment as best we can. There's much more we could say about that, but
I'm gonna ask that Dr. Ghamar come back on, because a lot of the questions, there you are. So Dr. Goettsche, towards the end of your portion of the presentation, you were talking a bit about suicide in older adults and depression. But in general, if you're working with someone where that there's self-harm, or they've told you that they're thinking about self-harm, do you have any thoughts about how to prepare in advance, other than asking them a lot of the questions that you're talking about in your tool, of course, and then the best way to talk to someone after self-harm happens? Again, kind of like addressing stressful situations.
For me or for?
Well, for either of you, but you can start, sure.
Yeah, I feel like this is more of a conversation that needs to happen with a clinical provider than potentially a case manager or an attorney or a guardian. I think this is a really sensitive issue, and you want to make sure that when you are bringing up sensitive issues like this, that there is no shame or judgment, and it's in a environment where the person feels safe and comfortable conveying what's going on.
I would say, yeah, that, you know, any concern for self-harm would call for a safety assessment, and that depends on the nature of the thoughts and the intent and the lethality and the history, and involving a clinician in that, and following through on a safety plan that, you know, in general, we look for the least restrictive measures possible. And if there's ongoing concern, or the symptoms aren't getting better, or they're getting worse, and there's imminent safety concern, then, you know, calling 911. In general, we try to work together to arrive at a safe outcome, and usually we kind of agree on that, but sometimes we don't, and that's a tricky part of the work. Then maintaining the relationship and repairing, and talking about the need to go to a higher level of care if that's not what the individual prefers.
So another very different question that you both got. Someone asked, during an emergency or mental health crisis, how do you get someone to honor a HIPAA waiver during crisis admission? And it seemed that maybe the issue is that the person who's helping admit them isn't a clinician, or the hospital won't talk to them, but they feel it's really important to have that information come to them.
I can take this one. I mean, I think that family members, loved ones, people who are working with them, they can always share information with providers. It doesn't mean that the provider has to share information with you, right? You can give some background, you can send an email, but they don't have to follow up with you. But if it's going to make you feel a little more comfortable in the process to ensure that you have the information given to the appropriate people, go for it.
Great. So I think that Dr. Goettsche, this one is for you. We got this question in the chat. Someone asked a question about how to begin the process of distinguishing between dementia and depression in older adults. And the context is that the mobile mental health team in their county often refers to a client having dementia, and thus not appropriate for a mental health response criteria. I see. So if someone has dementia versus some other mental health issue, the response might be different, and they go back and forth on appropriate intervention steps if someone's considered having dementia versus depression. So how do you look at those when there's so much of a cross?
Yeah, this is very tricky. And this, you know, the fact that this dilemma is so pervasive. Part of the issue is that in general, we need more support for older adults with dementia. And so, you know, differentiating is a clinical dilemma. You know, we look for subjective reports of depression. Is there hopelessness? Is there suicidal thinking? Things that we, you know, can occur in the context of dementia, but really sort of speak to the presence of depression. Do they have a personal history of it? Have they had episodes of depression before? Have they ever been hospitalized? Have they ever made a suicide attempt? That all leans in the direction of treating depression. Treatment of depression in the context of dementia is tricky. Our treatments tend to be more side effects, maybe less effective, and the interventions that can be really helpful are more sort of practical based. How do we ensure safety in the home? How do we ensure that they're able to meet their daily needs? Are they safe to shower, toilet, bathe, eat, you know? And so it's very tricky. I would say some geriatric doctors, primary care doctors, will have a low threshold to treat if there's any suspicion of depression. So I would include them in the conversation and say, you know, we think there may be depression here. What do you think about treating? But sometimes if it's clear it's dementia, maybe we don't add another medication into the mix and complicate things. So I would try to involve a primary care or someone else to contribute to the diagnostic clarification.
Thanks. Yeah, I mean, I'm sure for a lot of you out there, when I started working with older adults or people working with older adult population, it gets so confusing. I mean, even when you look at your presentation and like the symptoms that you were showing, I think for people who don't know that much about working with older adults, it's very surprising, right? So we have another question related to making a plan, right? So you make this plan, you talk about how the person can feel safe, coping mechanisms, people that are good support system for them. They have a mental health crisis and so much of it doesn't work out as planned. And now this person is saying, we came up with this plan, you didn't follow through on any of it, and I didn't get the things that I wanted. How do you deal with trust after that? Very good question.
Right. I think when you work with somebody with pretty severe mental illness, there's like a back and forth with trust, like it's ebbs and flows, right? And I think this is one of those situations where the trust is going to be broken a little bit. I think it's really important to clarify ahead of time that this is not a legal document. We're going to do our best to ensure your preferences are met, but ultimately this is out of our control. Like, it's still really great for you to feel like you're advocating for yourself. Also due to some of the mental illnesses at play here, they might not remember all of the details of the plan, or that you told them ahead of time that like this plan might not be followed by the rule of the law because it's not a legal document. So I think in those situations, in order to earn some trust back, maybe you could think about some of the actions that you've taken to encourage this person to follow the plan, or some of the actions that you've taken on their behalf to advocate for them, right? You want to continue to show that you're in their corner and that they can trust you, even though this document really, it didn't work out the way you all wanted it to, because ultimately the clinician wants it to work out this way too.
Thank you. Dr. Goettsche, we just got a question in. I think a lot of people would be interested in your answer, but I don't know if there can be a definitive one. That's my preamble for it. Do you believe that someone who has short-term memory loss can have the capacity to consent to an appointment of a guardian? I know it's loaded and there's law involved, but
it's a wonderful question, because mild cognitive impairment we generally think of as a precursor to dementia, and short-term memory loss is, there's many different reasons as to why one may have short-term memory loss that is or isn't related to dementia. So diagnosis alone doesn't necessarily answer that question for us. We need to have a handle on, can that person understand what a guardian is, what the purpose of meeting with the guardian, what the purpose of meeting is, what the consequences of meeting or not meeting are, and can they manipulate that information in a rational way and be consistent in how they express their understanding of that or not. So it's more sort of getting a sense of what is their understanding. Do they understand it fully and in a consistent way? And if your sense is yes, then they probably have capacity. If it's not consistently understood because they can't retain the information, they may not have capacity, but they may be able to assent to it. I don't know the legal requirements for threshold for meeting with a guardian, but from the clinical side, capacity requires to be able to consistently understand, manipulate the information in a rational way to express a consistent opinion. So they may or may not be able to do that.
So I have a question, and this is sort of on behalf of a bunch of lay guardians who we have here. Do you have any advice or tips on how to communicate with a person who, I guess this is more for you, Dr. Goettsche, a person who has dementia, and for example, refuses to follow up with medical visits or allow home care or is scared about relocating?
Oh, yeah, I would align with, I would start by aligning with the experiences of fear, uncertainty, hesitation, and try and understand that. Are they suspicious, mistrustful? Are they anxious and fearful? These are common emotional states for those with dementia. And so I would acknowledge that, align with it, and try and understand. Is it anxiety, inability to really understand what's going on, a sense of uncertainty that's unsettling, and so they avoid it? Is there paranoia present? Is it more deeply entrenched, and do they need some medication support with that? And depending on those things, you may just sort of, set the appointments up and try to get them there. But it sort of depends on, is it anxiety? Is it paranoia? And I would try to understand that and acknowledge that and help them feel a little safe in that experience to promote trust and rapport and encourage their cooperation.
See one more question. This is a question, it's a little bit out of the scope here, but let's give it a try in the last minute. At what point does a power of attorney or a healthcare proxy or a guardian step in for a person with cognitive decline in questions of moving, having procedures, taking meds? I think this is something that all of us can take, because this is part of my wheelhouse as well. I mean, with a healthcare proxy, the person isn't supposed to step in and take decisions and make decisions unless the person who signed the healthcare proxy is unable to make them. So like if you're in a hospital setting, you need the hospital staff to make the determination that that person is unable to make the decision before someone can sub in for you. These are all quite different legal arrangements. If there's a guardian that has already been appointed, who has been given the power by a judge to make certain decisions, were already given that power to make the decision. They should be talking to the person and finding out what they want and doing it in line with their wishes, as long as that person can be safe. But that's kind of another thing. Healthcare proxy requires the person not be able to in the moment. A guardian's already been given the power. And then a power of attorney, those aren't related to medical decisions. When you're giving up someone, when you sign power of attorney, you're also saying you're allowed to do all these on my behalf, kind of at any time, but they're supposed to be doing it based on your direction. It's kind of a loaded, complicated question. Maybe, Shira, if you want to email me after, I'm happy to have a discussion about it, but we are out of time. Thank you so much. For me, this went by very fast. I really want to thank you two for coming here, answering these difficult and important questions. And thank you for making this tool that just came out of conversation that the two of us had. I think it's going to be really useful to a lot of people. I know some people ask questions related to languages. Obviously, if you're looking and see that these are questions that you want to ask someone else in another language, it all applies, but right now this actual form is only available in English. I am putting in a chat a brief survey, so you can let us know how this went, but also to recommend any topics you want us to have in the future. I base all of these on all of you and what you want. So please fill that out or reach out to me. You can all reach out to me after if you have any other questions. And thanks again for joining, and thanks again, you two, for all this helpful information. Have a great day,
Bye, everyone. Thank you.
And I'll be following up with the slides. Yes.
Bye, Dina.
Bye.